So I'm going to give you a presentation on this topic of proteomic signature. So the title of my talk is going to be, is proteomic signature ready for prime time in thoracic immuno-oncology? So I'm a thoracic medical oncologist, also co-director of phase 1 early therapeutics program here at Northwestern. Um, and happy to give you my presentation on this topic. These are my COI disclosures. So just to tell you about the cancer ecosystem. So the point here is that we should not forget that it is the tumor and host that affects the outcome of the cancer therapy. And we oftentimes focus on the tumor factor, which are the driver mutations, tumor mutation burden, MSI high, PD-L1, so forth. But the real host factor, which is systemic immunity, which is reflected by the circulating protein landscape. There are environmental factors, patient factors, demographics, smoking status, and so forth. So to talk about the circulating proteome landscape and its relation to cancer immunology, we need to know what we are measuring and why we're measuring protein. So the measurement of protein proteomic changes can be provide measurable data points to really guide diagnosis, prognosis, and predictions. The circulating proteome is derived from tumor microenvironment, and normal host tissue. And circulating proteome changes during tumor development are at the result of can happen as a result of treatment. And really, circulating proteins can have direct regulatory effect on the immune system. And these are the classic plasma proteins that can be measured that have a certain role in metabolism, immune response, and so forth. So these are the high abundance to low abundance proteins that can be measured from protein. And you can really study these from bottom-up approach, where you kind of know what you're measuring, peptide, and you want to measure them precisely, quantitatively. And an example would be using antibody tagging approach, whereas top-down approach uses highly multiplexed, highly throughput approach. And in clinical setting, it's the MALDI-TOF is the assay we will be using to analyze the whole totality of the landscape. So this is an example of a proteome signature developed by MALDI-TOF spectrometer, and also using set enrichment techniques, using AI technology, and really develop them into different classifiers. And the example has been presented as a proteome immune response classifier, and this very slide was provided by Biodesix. And using the primary immune response PIR test, clinically, this assay was able to classify patients into resistant, non-resistant cases in non-small cell lung cancer patient receiving second-line nivolumab. As you can see, the median overall survival responder, non-responder, measured by, predicted by the PIR assay was 11 versus 4 months in median overall survival with hazard ratio of 0.48. And also the other, the validation study also confirmed the same results using a different cutoff. So this is what our group analyzed and presented at the World Lung last year. So we looked at all treatment naive patients compared to the others, the previous study, which looked at the second line EVO. So we looked at everyone receiving first line therapy containing immunotherapy. That's all immune checkpoint inhibitor first line. And then we looked at those ones who are receiving the combination of chemotherapy plus immunotherapy. And as you can see, this is not a large number, but still with this small number, we were able to show that there were trends for difference, and this, especially if you look at the overall survival difference, the resistant group and non-resistant group showed stark contrast in terms of survival outcome. And we've also came up with a hypothesis. If it has role in predicting survival outcome, then does it have any role in predicting immune-related adverse events? So we used primary outcome as time to first immune-related adverse event. And as you can see, for the sensitive versus non-sensitive group, also classified by the PIR classification from serum proteomic as signature, you could see that the sensitive group and the non-sensitive group seems to have a differential outcome in terms of both any grade, i.e. AE, or grade 2, 3, 4 AEs. So as you can see here, so I wouldn't say this is there's any definite conclusion, but you can actually see there is a trend for association, and this host serum proteomic assay can definitely have a role in predicting who will develop immune adverse events sooner with higher frequency. So again, just to give you an overview of what serum proteomic signature really means. I think conceptually you can think about a hot signature where there is a absence of systemic chronic inflammation. The chronic inflammation means the inflammation is not eliminated because of the chronic immune suppression present. And usually in this hot signature, you could have a good response to tumor treatment associated with better outcome with anti-cancer therapy, versus the cold signature would have chronic systemic inflammation present, but it is associated with ineffective immune response to tumor. And these are the immune cells, the key players that are playing a role in this interaction. So we currently have INSIGHT observational study results available to really see the role of serum proteomic signature in non-small cell lung cancer. And so this is a prospective study, but not randomized, but really just gathering all these genomic and patient outcome data for all these patients who have their serum analyzed. So what's really interesting is they separated this total of more than 3,800 patients into who actually got onto first-line immunotherapy and then higher line platinum-based chemotherapy. And the study was able to accrue 284 patients who received monotherapy with immune checkpoint inhibitor for treatment-naive non-small cell lung cancer. And among this group, if you look at the left side of the graph, you have PD-L1 high, which is usually the indication. This is the NCCN recommended indication of 50% or higher. So you have a median overall survival of 9.5 months here. Um, but as you can see, if the PD-L1 low, this is at the FDA current indication is 1% or above for pembrolizumab, but they had a 4.5 median overall survival, although the numbers low. PD-L1 negative was also there, but did have uh, higher median overall survival. But if you just choose the one that were PD-L1 high, this is the preferred group recommended by NCCN, and that's how I treat these patients, like PD-L1 50 or greater. I tend to put them on a PD-L1 monotherapy, pembrolizumab monotherapy. So here you can see uh, the VeriStrat, another currently available commercial assay, serum proteomic assay, with whether if it showed good risk, then you have median overall survival not reached versus poor risk 2.5 month. So uh, in my mind, this is a clinically meaningful difference, although this is understandably prospective observational study, not randomized. But if one assay is able to um, predict um, this much differential outcome, it would likely have a clinical impact in our clinical practice. So hazard ratio of 0.34 here. If you look at the ICI, immune checkpoint inhibitor plus chemotherapy combo for treatment naive group, you can see how they did. And PD-L1 level didn't have much impact, although the PD-L1 positive high group did seem to do well with the combo. But and then if you look at the good or poor risk by VeriStrat status, the hazard ratio is 0.6, but not statistically significant between the two groups. So pro group, chemo almost worked as a salvage to save these poor group on the left side to have a median overall survival not reached. And again, the right side subgroup is all PD-L1 high group. So based on this, although the caveat being not randomized with small sample size, PD-L1 high, if you have VeriStrat poor, you could consider doing chemo immuno combo rather than doing monotherapy with pembrolizumab. And really the VeriStrat results are predictive of outcome in patients treated with immunotherapy at all lines of therapy in advanced non-small cell lung cancer, independent of PD-L1 expression. So that's another take-home message here. So summary of my presentation is that serum proteomics can reflect host immune system and tumor microenvironment using top-down approach. And specifically, MALDI-TOF is used here. Serum proteomic signature can be a biomarker for outcome in non-small cell lung cancer treated with immunotherapy, both alone or in combination with chemotherapy. Insight observational study demonstrated that VeriStrat poor group was associated with worse survival outcome despite high PD-L1 expression in non-small cell lung cancer treated with pembrolizumab monotherapy. Again, it was small number, relatively 83 patients, but hazard ratio was 0.34 with median overall survival non-reached versus 2.5, VeriStrat good versus poor risk. Again, further studies are warranted to validate this finding. Serum proteomic signature may help select the right patient for single agent immunotherapy in patients with non-small cell lung cancer. So that would be my clinical implication from this or message from this observational study. All right, great. Thank you so much for listening. Bye-bye.